session, so it's we've gone a little bit in. So this is one of our favorite sessions, Ask the ONC. It's not just Ask the ONC. I know Matt and Al have got some other presentation parts they're going to do. There's some discussion about Uscdi and about the real world testing that Matt has warned us about. So Matt, if you want, I'll stop sharing. If you want to take over and display.
Yeah, I think Al's going to take display.
Okay.
First. Just to give background in who I am, because I think it's great. There's new people on this call today. We've got good numbers. So my name is Matt Rahn. I'm the Deputy Director of the Standards Division in the Office of Technology at ONC. I've been at ONC just over 10 years now. Worked with the Structured Docs group for probably like 6 or 7 years now. And hope to get some good discussion with you all, and we're going to talk a little bit mostly about USCDI. So I'm going to give Al a bunch of time because that is a hot topic, and we have some deadlines coming up in April that we just wanted to highlight. So I'm going to turn it over to Al, who is on the Terminology, Content, and Delivery branch in the Standards Division at OTech. So Al, take it away.
Thank you, Matt. The first thing I have to do is to say that this is our standard disclaimer. We try and make it as accurate as possible, but the reference laws and regulations apply and should be referenced along with state and local. This is the standard. I have to say it. Sorry.
Can everybody see those slides? Sorry, Al. Is it fine how he's doing? Or do you
I can see it.
Yes. Yeah,
okay.
That's great.
All right.
Okay. So today we're going to talk about the USCDI overview, including the different versions and the process, the expansion process, the certification resources, as well as Matt's going to talk about the C-CDA scorecard, and then we're going to brace for questions at the end. Sorry, this format's a little bit. So we published, this is the USCDI version 1, which we published about this time last year, which built off of CCDS. The intent was to use the USCDI for different use cases, including patient access use case, along with various patient care use cases as well. We added, compared to CCDS, we actually sort of rearranged some of the allergy data elements, but added some data elements as well to allergies, including the drug class and reaction data elements. Obviously, the new big ones were clinical notes, the clinical note data elements, and the provenance data elements. And then we added some additional patient demographic data elements, along with some pediatric. We changed the pediatric vital sign data elements from optional in the CCDS in our demographic certification to required. The USCDI applies to several different ONC certification criteria. Some of these are CCDA based or CDA based, and some of them are API based. But what it means is that these. So, for example, the API has to be able to exchange all of the data elements within USCDI if available, and for the CCDA-based documents, including transitions of care, all of the USCDI data elements have to be able to be represented within within those CCDA templates. And I think none of this is news to anybody, I think, on this call. The timeline elements are important for a lot of for developers and implementers as well as the developers of the standards like CCDA. The first one has happened already. So last June, opened the effective period of the cures update criteria. which means that EHRs can start updating their certification to either certifying to or updating the certifications to the Cures update criteria, including the ability to represent USCDI in full. That's the first one. The next one coming up is April 5th, in which this is primarily for information blocking purposes, that a response to a request for access to or exchange of EHI or electronic health information has to include at a minimum data elements represented by USCDI. That standard applies until October of next year, when an actor has to respond to a request for exchange of information to a change in the definition for EHI, which is going to be more expansive, but it's going to go beyond what was only required under USCDI. And then the other date that I wanted to cover, not all of the dates here, but the last date I wanted to cover was December 31st of next year, in which all of the provisions for the Cures update criteria has to be met. So in addition to publishing USCDI version 1, we also rolled out the expansion process that's for future versions of USCDI. And it was based on this platform, which I think most people are familiar with, called UNBEC, in which the public, any registered public stakeholder can make submissions for consideration for addition to USCDI. And we took a look at all of the submissions that came in up until the end of October of last year. We got over 600 submissions by, I think, 64 different stakeholders who submitted individual data element requests. We did an evaluation of each of those data elements and came up with a list of about 100 plus that were mature enough from the basis of use within systems, exchange between systems, and applied to a broad enough set of stakeholders to make it more appropriate for addition to USCDI, because USCDI is going to affect all users. Because we got over 100 of those level 2 data elements, we had to thin the field quite a bit, and we made decisions on what would get added to version 2 based on gaps in USCDI, so concept gaps. Things like encounter information, provider information were some of those. Not only were the gaps considered, but we looked at what the development burden would be for standards development, including exchange standards development like C-CDA or US Core, because those are the mechanisms that we use to exchange USCDI. And finally, we looked at the total overall burden of development for adding new data elements to EHRs, as well as the impact on the implementers or the providers who may have to modify workflow to accommodate the new data elements. And so those things together, all of those factors together led to our selection of several but not many new data elements and data classes for USCDI version 2. We added 2 new data classes, diagnostic imaging and encounter information. With diagnostic imaging, we added the 2 new data elements, diagnostic imaging order and report. For encounter information, we added 3 new data elements, encounter type, diagnosis, and time. We also added provider name and identifier to the care team members data class, and 2 new data elements, date of diagnosis and data resolution, to the problems data class. We also reclassified the 3 of the clinical note data elements, diagnostic imaging narrative, lab, and path report narrative, although we did not intend to change the implementation guidance that we have for any of those data elements. And then finally, we updated the applicable standards versions. So the SNOMEDs and the low-INCS and the RX norms had version updates since we published version 1. and so we propose to update those vocabulary standards to the most current versions for version 2. Now that we've published the USCDI version 2, we're in a period of public comment. That public comment really can run the gamut from, but it includes not only sort of regular individual public comments, but also comments from major stakeholder groups, like the Structured Docs Work Group, but any other organization can weigh in on what we selected for draft version 2, what we didn't select in draft version 2, and in any other changes to the standard that we have implemented or that others might suggest. The key time frame for a key date, which is coming up rapidly, is the 15th of April. Public comments on the data elements that we included in version 2 and the ones we didn't include are due by April 15th, after which we have to sort of put a stop on consideration of comments. Not that the comments can't come in, but we have to draw the line somewhere, and then we're going to take all of that information into account along with the input that we get from the Health IT Advisory Committee, and come up with the final version for USCDI, which we plan on publishing in July of this year. So where we're at right now, I'm going to hand this over to Matt, but where we're at now, again, we're looking for feedback on basically all aspects of the draft version 2. But at the same time, there's not only an open comment period, but there's the open submission period is ongoing now, and anything that's submitted now for an additional data element would be considered for version 3, just like the last year's was considered for 2. There also is an opportunity for additional development or information to come in on data elements that were determined to be level 2 for USCDI, but wasn't selected for the draft. It wasn't selected for addition. So these are data level 2 or even level 1 data elements. Might need some additional testing, some additional implementation, some additional standards development to be considered for version 3 next time around. So there's several components to the version 3 expansion cycle, and those are them. Although we had this submission period open until October of last year, we're going to move it up to make sure that we have enough time to process all of the submissions and give full consideration to what might get added to version 3. So we're moving the cutoff date for submissions to sometime in September. Once we finalize the version 2, going back to this slide, once we finalize the version 2, we are so the final USCDI version 2 will be considered for addition to what we call it the standards version advancement process. That will allow developers to voluntarily update their systems to the certification criteria that they were already certified to, that uses USCDI. They can update their systems voluntarily without having to go through recertification and retesting. So that again, that's going to be a voluntary process. But if they were to voluntarily update their systems, they would have to update to all of the new data elements. Yeah. I'm going to pass it to Matt and then start checking the chat to see what's coming in and see if I can maybe start answering questions. But I'm going to pass it over to Matt now.
Thanks, Al. Let me grab. I'll try to be quick because I want to make sure there's time for Q&A. people able to see my screen okay?
Yes, we can.
Is it fine that I don't go into presenter mode? Is this all right?
Looks good.
Looks
Okay.
good to me too.
All right. I'll make this a little bigger. Okay. So thanks, Al. Yeah, I wanted to bring up real world testing because I know it's on people's minds, but just caveat with this is all I'm going to give you for now. But there is just a small update. There is a date in the future targeted at the beginning of the third quarter to put out a resource guide for real world testing that will provide more context and how developers should be thinking about the real world testing requirements. I know Al just talked about SVAP, wanted to mention that here because that is part of that's where this comes into play, is the real world testing aspects. And SVAP, I can provide some links into where that is on our website. I don't know, Al, if you could do that. I didn't have that on there, but we'll provide those links and you can see what we've put in for the approved standards for 2020. Yeah, 2020. And it was very minimal, but we're moving. There wasn't a lot to be updated to at this point since we just released the Cures Act final rule around May last year. So didn't have any major updates. But as I'll mention, Uscdi version 2 is potential standard that when it's published could be part of SVAP. So a health IT developer with health IT certified to the B, C1 through C3, E1, F, G7 through G10, and or H criteria would be permitted to use the SVAP flexibility when when a standard is updated into the SVAP. And so I'll just leave it at that. But there is opportunity once we put it in. A standard's included in SVAP. We can consider it. There's an open comment period. Then we can decide whether it's beneficial for the community to move forward. So, SVAP is a way for us to not have to continually go through the standards or the regulation process where we can kind of push the envelope a little bit, again, voluntary. But, if you do decide to move to a newer standard that's been SVAP, you will be required to, update your plans and notify your clients and the ACB. I have two links there for real world testing fact sheets and the CCG. So please, I think you all have the slides, so please utilize those to resources to help answer any of your questions. And I'll put in the chat, if you do have questions or comments, we do have a centralized feedback system that in our website that would allow you to provide that feedback. And I encourage you to do it there because I can't really give you any more info than what's here, other than we're looking at beginning of third quarter to provide a resource guide for vendors. I'm going to the next slide. And okay, so that's on that. And then if you have a few questions, we can. I probably will not answer them right now, and I would encourage you to put them into the centralized feedback system, and we can route that through to the correct folks that should be answering them. C-CDA Scorecard. If you're new to this, ONC has created a C-CDA Scorecard that is a tool that goes above and beyond certification, and it leverages work previously that was in the SMART program, but essentially promotes best practices in C-CDA implementations, and there is scoring rubric that go into the background that gives you a score per se. And actually, I'll just for fun, I'll show it real quick. I know we don't have a ton of time, but this is the scorecard, ccda.healthit.gov/scorecard. I'll just do a try me, and you can see, like, if there was any conformance errors, any cures update feedback, like do you get any errors in the certification? It kind of shows you best practices, and this is not updated. I can show you real quick one that would be. I know I'm going to go through the rest of this really quickly so we can have more Q&A than us just talking. But here is the most up to date. There's about 105,000 that have been scored at this site. That is not the most updated at folks generally will install this locally in their systems and do their own. Don't ping our API, which since January, I think we have about 1,000 different pings on that, mostly CCDs. Okay, let me move on. Just a small background. So there's the link. Quickly on how does the CCR get updated? CCA Scorecard get updated. Anytime there's a CCDA validator update to for the certification program, we do update, which is generally the last Monday of every month. There could be in between if there's any errors. If there's any new rules created by HL7 in an informative guide, and I know we don't want to get too much in this, but I know that Gay will probably talk a little bit about it. There is an informative guide with rubric that is informing the CCDA scoring methodology in the background. And so I'll get to that part in a second on how you can provide input, but there is also a one-click scorecard. I can provide the link to that, but that is so you can send a direct email to scorecard@direct.hhs.gov, and you can send PII for using that. And if you have a direct address and receive the feedback on the CCDA you have. There's multiple different ways to download. If you go to the website, all of the there's an API and there's external tool instructions. We have our GitHub page on how to download, and it shows you how to download the scorecard for local installation. ONC support long term. I've mentioned this a few times, but for new people, obviously we're based on appropriations. As long as we get funding, I can't guarantee that this will be up, but I can tell you that most likely we will support this. We will continue to support this, and the plan in place, I can't guarantee. I can never say like it's firm, but the plan would be if there is a new update to the informative guide or new rules that we've created through the example task force, and they get approved, we will do our best to update it. And that's kind of where I get to the how can you provide input. So I mean, based on discussions we have here today, there may be some new rubric rules that get put in place, and those are ways we can start tracking as a group. Is there 10 to 15 or 20 new rules that we want to add to the informative guide and reballot and re-release a new version of the informative guide? And we can provide links to that, but that's just one way we can do that, and that's part of this community. And we participate and are always open to updating. I'm going to go to the next slide, and it's just resources. The Uscdi, I put some in the chat. The draft, again, April 15th is the last day to comment on draft Uscdi version 2 and any of the the class, the data elements that are classed, level 1 and comment, and level 2. Links to the scorecard and the GitHub page, and then finally we've instantiated this new standards bulletin that you can sign up to receive. We'll probably put one out 2 to 4 or 5 times a year. It kind of if you go to that link, there's one right now that talks about the some of our thinking behind why we chose the draft Uscdi version 2 and the SVAP, and how they're aligned. So in the interest of time, I'm going to stop there and just go to this play, the Ask ONC.
Hey, this is Matt from Epic. One question I've got for you is whether USCDI scope-wise includes stuff like scanned images or PDFs, like whether being able to support exchanging those is intended to be part of the requirements.
Have you submitted this to the centralized feedback system?
No.
Okay. Can you do that? I would before I answer.
Yeah, sure. Sorry, it's kind of like a
Matt. This is Lisa. Yeah. One interesting spin on your question is I would ask, for example, if you've got a document reference like a unstructured CDA that's carrying a PDF, what LOINC code is telling us the kind of information that's in there? And if, for example, it's a consult note, there's LOINC codes that are already covered that say this is a consult note. It might not be a coded consult note, but it's a consult note, in which case it is part of the clinical notes area of USCDI. With or without discrete data in it, if the PDF thing that you have is a consult note, it's still a consult note.
But is it, can I ask, this is Emma, it is still a consult note, and I think maybe, and to the question I would ask is, if I send that as an unstructured document, this is the XDS-SD, will that serve for a clinical note rather than using the note activity template? Am I misunderstanding?
I mean, I was sort of thinking of like that question from the other way around, where at least Epic's in a position where it's much easier for us to, support stuff like the standard clinical note template, but then unstructured docs are kind of in this murky area where we're not sure how much support for them we're obligated to have based on the requirements in USCDI.
I know what I think from an implementation standpoint, we've talked about this in example task force, for clinical notes as a note activity, which is structured, that can be within a section, inside of a document. It seems as if the text, which is the example that Epic provided, okay, that's supportable. But if we had like an image to place in the middle of a document, like in a section, that doesn't seem to be easily supportable based on the CDA structure, that structure that's there. Can we support that as an unstructured document? From a use case perspective, so I'm a provider. I want to send my images of the wound. Can I put a LOINC code that says, whatever it represents the wound or whatever, or consult note or progress note, wound progress or something, and put those images in that unstructured document using a document template, XDS-SD, and send that? Would that be considered a clinical note? From a certification perspective. That's what I mean.
Yeah, and I mean, I'm sort of as unsure as you are about.
I know, I'm not asking you. I'm saying when you ask ONC that question, as Matt directed, you to do.
Yeah. Can you put that into the? I know Al put in the chat the centralized feedback system link. And that just allows us to, make sure that we're saying the right, we're trying to convey the answer that, or respond to the question that you're asking correctly.
Mhm.
So
Yeah, the question's been asked a couple different ways just
Yeah.
now.
Yeah.
So it's cleared. We need it. Every question is specific, and every answer is sometimes specific.
Yeah, I got you.
We can
Yeah,
And I'm hearing Matt talk about unstructured documents, and Emma, I'm hearing you talk about unstructured information within a document that is a structured document. So I think that's a distinction that we definitely
Yeah.
need to.
to separate, I think that's where we needed clarification. The one thing
Yeah,
about,
it's, go ahead, Emma.
no, I was gonna say, it looks like the ONC tool, and Matt, this was the email that I sent the other day. Well, only if I ask a question, I can see the response to me, but I cannot. Is that how it works? So if Matt from Epic asked this question, I wouldn't be able to see his response, because I think that was the thing I was. You guys shared a link of structured document. I hit the link, but I couldn't see it because I didn't ask the question.
Did you do you have an account, I guess?
Oh yeah, I have an account and I've asked questions on there before, but I couldn't get access to
I
the
think the
question.
follow-up, Emma, is that we should like to take the action item to follow up with the ONC to make sure that this process works, that all the questions and all the answers are publicly viewable so that we can all learn regardless of who asks the question.
Yeah, so I think that was what was, I don't know, maybe it wasn't.
I'm definitely happy to, provide the responses publicly to those questions. But if you wanted to, if it's not public right now for you to see, if you want to send us a note requesting that, we can talk about that internally.
Yeah.
And that's something we can look at making more transparent.
Yeah, I have another question. I have a question. Unless somebody else.
Yeah, so Emma, just to say, I put in the chat the Uscdi, CCG, and the third bullet on clinical notes may talk a little bit about what you're referring to, Matt, about the maybe a little bit on it's just the not converting a machine readable format to a non-machine readable format. But if there are things that are asked in the centralized feedback system that we have that clearly needed to be clarified in a CCG, we can add a bullet to clarify the intent.
Yeah, perfect. Matt, this is Dennis, just to clarify a little bit, what I'm hearing, like when I looked at the Uscdi version 1 and it talks about clinical notes, it also specified, drop downs and text boxes and check boxes that they all had to be encoded. And in optometry, pretty much everything that they recorded in the exam would then be in some ways a clinical note. So what I sort of hear Matt saying is, can we encapsulate like an exam summary or an encounter summary, which has all of the data in, say, a visual way, more of maybe HTML tables that we can encapsulate into a document and then use that as a clinical note that we can embed into the C-CDA.
Yeah, exactly. Like C-CDA, is easy and standard, and we know how to handle it. But when you get into the realm of, well, are we exchanging also, PDFs or, anything else, then it's,
There
the
was,
limit.
sorry,
Go ahead.
Matt, go ahead. I was just going to say, sorry, Matt, there is like, when Lisa mentioned and showed a little bit of the C-CDA online, I noticed that there's, that's more of a consolidated tool. I've always struggled a little bit to try and find the right companion guide, the right examples, the right tools. And, with the GitHub and the C-CDA online now, I'm finding that's a little bit better. But there are samples in there that talk about encapsulating a PDF. I think it's maybe base 64 encoded or something like that, where you can encapsulate images, but I'm not sure whether that would be acceptable from the clinical notes, because as you're aware, I'm sure with Epic, that there's so much recorded in the exam all over the place that if you had to put everything in there, if it was considered a clinical note, how would one do that, and would it be accepted?
We do have a similar question regarding to clinical notes, or like the types of the clinical notes. Like we have a let's say one customer signing the consultation note is a kind of visit summary. It has problem list, it has reason for consultation, history of present illness, medications, allergies, etc. Like, is those notes are meant to be use that type of information, or what is the the range, or what is the expectation, the consultation note in the C-CDA, because there is document types that they can send as well, but since here, even though it's kind of coded, but in the HTML human readable, you can have from machine readable, you can have a reference to the human readable, and they can send a good bit of information, and they are preferring it. So, but does it make sense? Does it acceptable? And it is increasing the size of the document, and how those are having having benefit versus having not benefit because of the size issues that systems are dealing with.
From my perspective, like medications and allergies, everything that has a section available for it, we should use it. So for me, it would be all about the, also all the unstructured, all the sections that don't have a place to go. Like, so we have medications, we have allergies. When you do a consult note, there's going to be in one of the guides, if you check on, if you're searching the C-CDA online again, and you type in consult note, it'll give you a document. And then unfortunately not on the search, but if you click the view PDF, it will actually give you all the sections that are required for that type of document. So the consult note is obviously it's a note activity that you can include, but it's also a document type. And one of the things, Matt, that I was struggling with was using the different document types that were available for 2015 edition certification, and then trying to validate them. The validator, or the scorecard, sorry, is a really good tool. I used to embed the validator in RHR, and then I changed to embedding the scorecard. But the scorecard really only wants to see a CDA 2.1. It sort of schema validates the referral notes and the consult notes and the progress notes and things like that, but it doesn't always pick up all the different sections and things like that, because it wants specific things. So I think from your perspective, Özlem, is it Özlem? I'm sorry, I don't want to pronounce it wrong, but I think at all the sections that are there, I think we should put the data in the appropriate sections, and then when it's not available, like it's the drop downs, the check boxes, the areas where the doctor describes a plan, maybe in a very free text note form of way, those are the things I would expect to be part of the clinical notes. And they're just, for us, it's all over the exam. Like, there's so many places that data could be recorded.
I have a question for Matt Rahn about the scorecard, to following on Dennis's question. And is it possible to architect that scorecard so that when it confirms a document, it reads the document type from clinicaldocument.code, and then, of course, any required sections need to be present. But could it validate the content based on what sections are in fact present, and have more of the validation be driven that if this CDA document includes a social history section, whether it's required or not required, we know what a social history section should have in it, and have the validator validate that social history section, or the health status evaluation and outcome section. If one is present, validate it according to how that section is meant to be validated, rather than, it seems like right now, if you've got a LOINC code at the clinical document and it's not a CCD, you have no idea what the validator's behavior is going to be after that.
Well, Lisa, this is something that we actually had to struggle with a little bit too. We do data quality for a lot of our HIEs in the VA. And for our scoring, just because we encountered this exact issue that you're talking about, for non-CCDs, we run all the checks for all the other sections as they're provided. But for any optional or open template, which is it wasn't even recommended to send that section in that document type, we have found that to provide comparable scoring, you can't, we raise all the same alerts, but you can't count that towards the score. Because if you do that, then you basically make it impossible to compare a discharge summary or a consult note between vendors A, B, C, and D.
Very reasonable approach, John, right? These are all bonus sections, so they don't count against your score, but really most people are looking for this to see what are the compiler errors, where are the warnings, where are the benchmark best practice notices that can help me understand if I've created a good one of these sections.
So we get all we raise all those.
Yeah, it's a very good tool. Like, I'm very happy, and the long-term support that Matt Rahn talked about was, how long is that going to be around and stuff like that. If EHRs are going to send documents, between systems and things like that, when I receive one, I want a scorecard to see what the quality of the document is, and for we should even be scoring our own before we send them so that we can try and improve the quality. But I ran into a problem where I get where you're coming from, John, on that part of it. And I get that some of the sections aren't going to be able to be scored. Like, we're having a problem right now where we have no conformance errors, and we're getting a no. It's telling me that the patient birth date precision is wrong, which it's correct. I even took the sample from the high scoring, put it in, and just changed the details. And it's basically, it won't even recognize any of the other sections within the document. And this happens to be a referral note. So it's not a, standard C-CDA. And I'm finding that's also happening with the consult note. And it's kind of, I'll obviously have to submit some tickets on all these things and kind of work through it. But it's a really good tools for EHRs to actually improve their overall quality of their CCDAs. And referral note and all these types were required for 2015's, edition of the certification. So I would hope or expect, at least to some degree, that they'd be supported by the scorecard in a greater degree.
But are they required?
They are. We had to actually prove it in 2015. So we had to show a referral note we used Drummond as the ONC, and we had to show like 8 different document types to prove that they were valid and throw them through the validator. So if the ONC scorecard is following the validator, I would hope that it would kind of conform to the same rules. But
like progress note, for instance, is one of the clinical notes. But not necessarily required by ONC. Am I saying that correctly?
You are, yeah.
Okay.
So progress note is really, the note is actually applies to a bunch of different types of notes, to be honest, the note activity. So the document type, the progress note is a little bit of a different one, but the referral note was definitely one that we had to produce.
Absolutely, yes.
Isn't progress note is on the list for clinical, not as a document, not progress note document, but progress note clinical
No,
note.
clinical as a note, yeah, and that's been a real problem for our clients, because a progress note, we have examples of that have all the data needed that kind of goes in a C-CDA in the progress note. So why not create a whole nother document? Well, then they don't want to, because it's supposed to be in the CCD. So then they start just shoving stuff in the CCD.
Yeah, I mean, it in general, our stats are essentially like 95% of the folks scoring a CCDA is a CCD. It's quite high,
right,
especially even still. But I mean, this is, great discussion, and I think I know we're over time, but if you do have any specific to the CCA scorecard, any thoughts on how we can improve it, reach out to me. But from a, kind of to your point, Lisa, I know that there's some social history rubric that is in the current informative guide. If there's something that maybe we could add there that would allow for, some of those optional sections to be required, because essentially in the scorecard, we've made based on some of the rubric, we've made those sections required that are generally not. And so that's how you would, be scored on. But definitely happy to touch base more on the scorecard part. I just, wanted to make sure, given that we're like, 20 days away from the USCDI deadline to comment, we focused a lot on that. And I want to give one other plug is Monday and Tuesday is the ONC annual meeting. I can send another link for that. So there's going to be a USCDI SFAP specific session. You can learn, it's way more in depth than what Al went into today, but you can learn more about those two things. I'll put the link in the chat, but
sorry, Matt. Can I ask a quick
yes.
question about something that was on the presentation today?
Yeah.
The list of the slide that actually says, how does USCDI relate to ONC Health IT certification program? You have the case report implemented, a case report on that list. The case report, electronic case reporting, the case reporting implementation guide does a mapping in volume 1 on page 19 and 20, have a mapping to USCDI V1. And in their list of mapping, they're not including everything. They don't have provenance. They don't have clinical notes. My question is,
which slide are you talking about?
The electronic case reporting,
which slide particularly are you talking about?
The slide, I don't know, I think it was the third slide, fourth or third, the one that had USCDI relate to.
It was the criteria table.
Okay, yeah.
Yeah. So, and the reason why I'm asking is because dealing with CDC and their tool, they can be very picky as to what goes in their implementation guide or in their documents we provide. If we start throwing things in there that they don't like or that wasn't in their implementation guide, it may cause problems for us. Are you saying we need to add?
Emma?
Yeah.
No, so I got, I'll answer and then you can add. So for F5, it's there's obviously, if you go to the CCG for F5, it'll tell you the specific criteria or data elements that apply. So it's not every,
Okay.
it's not everything. And so I can, I can pull that up and just say it. Sorry.
Okay.
Oh, you want me to pull it up? I can show it. I've got it right now. Oops.
Okay, yeah, just show that. But essentially for that one, we say that you only have to meet a certain subset of the USCDI data elements.
All right, thank you.
They're listed there, so yeah.
And Matt, before we let you off the hook, Patrick Payton has a question in the chat.
Yeah,
I have a couple questions for the real world testing measure. Is it an expectation we keep track of the number of successes our customers have with the real world tests? And 2, the October 2022 date for EHI data that is outside USCDI, does this mean we would need to update items like the C-CDA?
Yeah. So if Patrick, if you could put both of these in the centralized feedback system that we put in there, but I'm going to stay away from number 1, but I'll answer number 2 is, on or after October 6, 2022, the actor must respond to a request to access, exchange, or use EHI with EHI as the definition of EHI. So you have to, after October 6, 2022, you'd have to, the exact definition of EHI is what you would need to cover. It just essentially, it becomes way larger than the USCDI. But if you put that into the CFS, we can give you a more official response.
Okay, thank you.
And for some of the info blocking related questions, there was a webinar not too long ago that we had, and I put a link in the chat. And you can see the slides there, or listen to the webinar that gives more information on the information blocking section.
And also, Matt, there's a question from Linda Michelson about the behavior of the alternate path. When you're using the scorecard tool on production data, it used to present you with a different level of information, not a detailed view of what the errors were. She's asking does that still, that PHI scorecard still have that behavior where it only gives you the summary info?
Yeah, I believe so right now, but what we've, and we can, I can take that offline on how we, if you have thoughts on that. But that generally, that tool was meant for providers that, had received a C-CDA from another provider to score it. So we didn't want to get too much in the weeds.
But like in Dennis' use case, where he's encouraging vendors to use this to understand the quality of their own documents and the quality of documents they're getting, I think you do need to open that use case to show the details, just like the others, just like the test data details.
Something we can think about.
Go ahead.
Sorry, Dennis. Just to add on to that, like that's something we can think through. Most of the vendors that we've heard from have usually local install, so they're able to, use their PHI, like score a PHI essentially internally. So
I was just going to say the same thing. Yeah, you can download a local copy of the schematron and everything, and then run it through a Java processor to get the detailed view without using the other one.
Okay, we have to worry about time because Gay needs to get rolling and be in and out of here on time. Our break has shrunk now to just a few minutes.
Yes,
John, what do you
I was
suggest?
letting the conversation go because it was a good conversation. Matt put in the chat, if you've got any other questions, especially about the scorecard, you can email him. We've got about a 5-minute break between now and when Gay starts. So I give you just enough time for a bathroom break, refresh your tea, and we'll be back in 3 minutes, 4 minutes. Did want to point out the votes were in and over wins, which is good. That's because people who do under, you're wacko.
I am wacko.
Yeah, well, you're also
okay with that.
Here's the patent for the toilet paper roll, and it shows in the original patent, 1891, it was intended to be over. So
yeah, but if you have cats and you have children, you put it under.
Oh,
They can't roll it all over the place on you.
My dog has a pain on this.
Edge case.
I'm saying I got the edge case.
I just can't prove the patent when the sheet's so small.
Yeah, good point.
Suggestion for next IAT to do ask ONC for 8 hours straight.
Yeah.
And this is only one example of the patent. I'm sure there are other patent pictures where he has both one or the other and not just this. Whatever this is over the top.
The patent really only has it this way. That was the
only
big
one
thing,
time.
The patent only has it this way. Because he rightfully so thought that people who did it the underway were should be committed to an insane asylum.
No, actually, I think we just enhanced the process.
I think we did.
At the time, way back then, he was a male and didn't have to take care of children or cats. I'm just saying.
Whatever excuse you want to
I hear you.
He probably was right-handed too. So I know a lot of left-handed people who put the paper roll, the actual paper roll on a different way, like what you use to dry your hands with. They switch it around. So maybe he just was a right-hander and he didn't know. I'm right-handed too, so
I'm a lefty, and it's good. I have one job now. At 50 years old, I realized my job is to go through the house, turning lights off, closing doors, and making sure the toilet paper rolls are on the proper way. That's my.
Well, what about the people that just sit it on top of where it's supposed to go?
Those people, can we all please agree
what
those
is
people
that?
are just wrong. Like when you just sit it on top, that's just wrong.
I just
that
don't
is
understand.
lazy.
Like,
That's
it's
what
so close. You're so close, but you're just not there.
That'd be my 18-year-old son who doesn't replace roll. So you go in and you're like, it's done. You could have gotten a new roll. Come on, what's going on?
It's my husband, and then moves it to the counter to blow your nose. That's what Kleenex are for. Leave the toilet paper where it's supposed to be.
What's your deal with the doors? Because if I ever had like any kind of housing situation with 2 stories, I don't think I can do it. It's too many doors for me. I can't do, you know.
Why do you
It's
close
not
the
like not the
doors?
regular doors, but cupboard doors. I mean, like
Okay.
kitchen door to bathrooms and the door
Yeah, that's
wide
me.
open. You're like, what the heck?
I do that too. I wonder if it's an under the roll toilet paper person that leaves cabinets open, because I leave cabinets open.
My wife is an under the roll person. She leaves all the lights on, and she
Uh-huh.
probably leaves the cabinet doors open. She doesn't.
Okay,
put it
so
away.
there you go. I think it's a thing. I'm always going back to that cabinet, so there's no need for you to close it.
Leaving cabinet doors open is a short person thing.
Yes, yes.
There you go.
Tall people hit
Okay.
our heads on the cabinets, on the corners.
That makes sense, actually.
And what
And
if
it
you went
hurts.
from being an under person to an over person at some point in your life? I mean,
Why
what does
did
that
you?
say?
Why'd you switch?
Because I moved into a new apartment that had these fancy toilet paper roll holders with a pretty metal sheet.
Oh, little silver thing on top, or the little gold thing on top. Yeah,
and
you
that
have to do
really
that.
argues for over the top.
It does, unless you want to just dig underneath and grab it.
How many people buy 2 packs of paper towel, like 2 16 roll packs,
Mm-hmm.
and keep one upstairs and keep one downstairs? That was the advice from my millennial child. And I'm like, oh, you young people.
Because they can't run downstairs and get a
No,
pack.
no.
Right,
Like,
right.
why didn't you just get 2 packs?
Well,
That's
let me
the
tell you.
reason.
Go ahead.
I'm gonna say that's the reason why we ran out of toilet paper during the pandemic.
Yeah, yeah.
People trying to put one roll
Exactly.
at the bottom, another at the top.
I actually stopped buying paper towel rolls during the pandemic because I got so frustrated with the waste, and I started buying napkins, and I made everybody in the house use napkins. And we did that for 2 months. And you know what? I bought paper towels again, and they're not running through them. They actually appreciate them.
Well, it was funny during the pandemic. So we have 3, a basement that's finished, and so we had a washroom down there.
Mhm.
And it was funny, around July, I think, or August, I went in there, and we didn't even realize that my son had brought down one of those 16 packs downstairs and had stored it in the bathroom in the basement. So we're like, we're conserving toilet paper in the upstairs bathrooms. And I go, and I'm like, we got like 15 rolls down here, because no one uses that washroom except for him when he's playing his video games. So
He's pretty smart. He hoarded it. That was
Yeah, he's taking care of himself.
Gabe Dolan is up. We're at 147. Gabe from a new Namaste Consulting. You're going to talk to us about structured doc and some comments around Uscdi, I think.
And calm us all down at the same time, Gay?
Yes. Gay,
Yep.
are you there?
Yep. I'm here. Sorry.
Yeah.
Just clicking all the appropriate buttons here.
Okay, cool.
Okay. Let's see. Did I share my screen yet? Share your screen. We're gonna do this screen.
Perfect. Yep, we can see your screen. Ooh. Pretty horses.
All right, so this is topic 3. We are not really talking about Uscdi v2, but rather we're having the discussion about the discussions that the Structured Documents Work Group had about the implications to C-CDA. So what Structured Documents did, because HL7 wanted to contribute comments to the draft USCDI, and that is done through HL7's Policy Advisory Committee. And so we convened a task force, which is a subgroup of anyone who wanted to participate that regularly attends Structured Documents, to talk about the things of importance. Not necessarily, we did not talk about every single data element, but rather a select few that people had expressed concern about. And so our goal today is to review those discussions and get your feedback on what our takeaways were about about the items and the comments that we made. And now we already, as structured documents within HL7, had to provide our comments to the HL7 Policy Advisory Committee, and they will submit by the ONC deadline of April 15th. So, but you are, as we've been discussing, very much encouraged to go ahead and add the same comments or additional or different comments with respect to these topics. And so these are the areas that we focused on. The problems, which within problems, data diagnosis and data resolution, the diagnostic imaging change in class and elements, narrative versus report, encounter information, reflecting encounter diagnosis, et cetera, and a few things about care team. Those are the things that we focused on. And my slides are essentially almost notes. You know, normally I create slides with very little words, but I wanted to really expose the notes to you guys and the thought processes. And I'm even, you know, going to bring up a Word document with some additional detail about diagnosis state. So with respect to data diagnosis and data resolution, we had a couple of general conclusions that one of which was that we would provide a comment that we need to bring in, if we're going to be bringing in diagnosis state, that we also, we need to bring in date of resolution, date of onset. And we also had mentioned recorded date. However, recorded date is what's often captured and is not necessarily something focused on, and so it's not on the level 2 USC data elements, USCDI data elements. And so we crossed that out, but we thought that there should be a note that, well, that's fine, but we should note that this is often a captured date and we want to move away to more clinically relevant information about dating. We need to provide more precise definitions for each of these date-time elements. And so we actually had some folks, I think Dr. Holly is on the call today, and her and Dr. Stephen Lane provided some precise definitions, which I know ONC likes. If you say provide a precise definition, please at least suggest what that definition should be. And so in that case, we're trying to do that. But even so, there was still some discussions that occurred. So we wanted precise definitions and examples for diagnosis date, resolution date, and onset date. And we also recognize that structured documents work group needs to provide, depending on what comes out in the final USCDI V2, we will need to provide guidance with respect to representing diagnosis and diagnosis date, onset date, and recorded date. Even though recorded date's not in there, we need to differentiate. How we're going to do that? We figure there's a couple different ways that may or may not happen. Certainly C-CDA examples task force is the easiest, but perhaps not as publicly available as something like companion guide updates. So some of the things we talked about with respect to the updating, that we want to consider if current modeling can handle it with some more precise definition, or do we need to add extensions, and how will recipients know? Do we need to have a new template ID? These sort of things that we'll figure out as we're developing guidance. If we develop guidance, things that some of the folks that folks brought up on the call is, how would the recipients know that the new guidance is being adhered to? Do we need a new or different or additional template ID? And I think I mentioned this already, that even though we had brought forward recorded date, but in fact we're going to suggest that, but then realized that we actually couldn't, and then we still are recommending to at least make a note about that. And then we brought up the fact that provenance should be able to capture recorded date. Maybe that's, I mean, the tracing of it anyway would be where recorded date could be captured, but even so, you're going to have an initial time where the recorded date is captured. And I wanted to bring up, I know I'm going a little bit fast, but we started late. And so maybe what I'll do is and Jean, maybe you can give some recommendations for this. I can stop after each category and we can chat a little bit, or we can wait until the end to chat about these different things.
Yeah, I think if you go through them and then we'll chat about specific ones, that's probably the best. Get through them all.
Okay. And I'm talking too fast for people to understand. You'll have to tell me to slow down too. Let's see. Let me bring this up. Come on.
We are following along.
All right. There we go. Okay, so these are the definitions developed by Dr. Holly Miller and Dr. Stephen Lane. They participated in the committee. And we did have some additional, you'll see some text here, Dr. Miller, probably that you didn't add. This was the final thing we submitted because we still had questions. And so the onset date was put forth. These are what we put forth for the Policy Advisory Committee to submit. Date patient reports symptom. Onset date is the date the patient reports symptoms, that the symptoms began, or the known date of an event leading to an establishment of a diagnosis. And this may be an approximation. One of the things that they wanted to note is that this field should support fuzzy dates. How fuzzy you can get is in CDA will be a year, right? Really, that's the fuzziest. A diagnosis date will be the day when a physician or other healthcare professional first established the diagnosis, maybe a diagnosis by a pathologist or radiologist or some other specialist, or a provider who ordered a test, etc. And then we had asserted that in addition to that, if this turns out to be a required need to accept that it may be unknown. And if it is required, because we said that it's focused on an efficient physician or other healthcare professional first established the diagnosis, really sometimes you just won't know. If it's required, we need to have perhaps an additional date field called reported date of diagnosis. So a patient says, well, I don't know, I had diabetes when I was 10. I was diagnosed with diabetes when I was 10. I don't really know who my provider was. I don't know anything about it. I just know I've had diabetes since I was 10. We discussed should this be a non-clinician reported date of diagnosis or just reported date of diagnosis? But this is what we need to call out that also, in addition to that, you need to call out that the diagnosis date is indelible. So in other words, if it's been, the first time it was diagnosed, whether it's really a reported one or the physician initial diagnosis, it's something that's going to be sticking around. We also brought up that sometimes in some systems, rather than on a problem list, the date of diagnosis is only associated with an encounter and only associated with billing codes. So that's something else that the group had a concern with. Again, bringing up here recorded date, which is to be sure that it's differentiated between recorded date. This is a note that both the docs brought up that this is a diagnosis may evolve over time. I think we initially used to handle that in the concern wrapper in C-CDA. We know that is that's still, this is everyone agrees on this and how it's managed with respect to knowing that this thing that was recorded was a diagnosis versus just a problem versus a symptom, whatever, that these are things we will have to consider when we advise. Resolution date, we didn't have too many, we didn't as a task group have any additional comments on this this definition date. The diagnosed problem was completely resolved. Well, sorry, I shouldn't say that at all. We did have questions because we had concerns about that. This is rarely something that is, these sort of concerns, that they are rarely something that is actually followed through on when for a clinician to go back into the EHR and to put a resolution date on. For example, it might be the next time a patient visits, and so it would have to be posted. And so somebody goes into an office,